Okay, we are live, madam.
Yeah. Good evening, everyone. So we are starting this laparoscopic master classes, just like how we did the fertility master classes, because there are a number of queries from juniors and postgraduates and even like practitioners who have been doing open surgeries and who want to move on to the laparoscopic surgeries. So we thought many a times we have this problem of bladder dissection. So let's start our first class with bladder dissection, because that is, I think, one of the most important steps where many beginners will get stuck. And I myself, in my journey of endoscopic surgeries, have faced this problem multiple times. And I wish with these classes, I wish like the endoscopic surgeons become better and they start doing more and more keyhole surgeries. And yeah, any queries, we're always there. So though it may not be like a fertility class, which is dry and which is more theoretical, but I think the practical tips which Dr. Jay would be able to give will definitely help you to enhance your skills. And whatever possible through these webinars, we would like to do it giving our 100%, and expecting a hands-on may be tough with our kind of practice here, but we will try and motivate people to actually take it up in a more serious way and to advance their skills with whatever little knowledge I have, definitely. So over to you, Dr. Jay.
Yeah, just 1 minute, ma'am. I just need to make sure if we are also live on YouTube, because I'm just unable to see that at the moment. So just see if you can see if we are live on YouTube,
Yeah,
because
yeah,
I'm
we are. Come.
we are we
Yeah.
live on YouTube?
Yes.
Okay, fine. So that is great. So guys, thank you so much, and I will straight go to the point. So remember, when you are trying to do bladder dissection as far as any of your surgery is concerned, right? The most important thing to remember, probably through these master classes, is the principle of doing the surgery. Don't try and understand if my technique is as good as yours or yours is as good as mine. That doesn't matter, right? If you are doing open surgery, if you are doing vaginal surgery, if you are doing V notes, if you are doing laparoscopic, robotic, whatever you are doing, the principle of bladder dissection is going to remain absolutely the same, right? And in this session, of course, I'll be showing you a small video, but you have to try and understand that in this session, I will be trying to discuss why you have to do a particular step through the video. Okay, so I'll just try to discuss that. So if I can share my screen, just have a look at this, Shilpa madam, if you can see my screen.
Mm.
You can see the screen, right?
Yeah.
Fine. So, okay. Let me try. Fine. This is not a good video to start off with. Okay. This is a very good video to start off with. Okay. If you see, normally, this is exactly how the bladder, utrovesical fold, and the uterus are. So if I just pause everything here, the most important step in doing a good bladder dissection is what you will note in this video. It has got nothing to do with the bladder, right? It has got to do something with traction of the uterus. So what is important is, even if you don't understand anything else, let's say you are doing an open surgery, give traction to the uterus in the cranial direction, right? Very, very, very simple. When you are doing a cesarean section, this traction to the uterus has been already provided by the baby, because the uterus is 36 weeks old. Okay. So what typically happens is that size of the uterus automatically provides cranial traction to the uterus. Same principle of obstetrics to be followed in gynecology. Look at this. The uterus has gone above the pelvic brim. Now you can use a uterine manipulator from below. You can use a myoma screw from above. You can use whatever you want to use to provide cranial traction. As long as you provide cranial traction, utrovesical fold will start behaving something like this. I'm not even holding the utrovesical fold, but because I'm giving cranial traction, bladder dissection is over. Okay. And bladder dissection normally for a normal bladder like this is going to take approximately 3 to 5 seconds. If we are doing it slowly and if we are trying to have a teaching video, then maybe 7 to 10 seconds. But remember one more thing. Okay. Once this bladder has gone down, you will see this structure which we are coagulating, and that is the uterine artery. So uterine vessel is going to be your anatomical landmark for the bladder, because uterine vessel originates from a different embryological compartment. Okay. Because it originates from a different embryological compartment, the bladder will never ever cross the uterine vasculature. So if in case you are in trouble in bladder dissection, dissect the bladder and you will see the uterine vasculature. That is why in TLH, TAH, whatever you do, you are always told that first you go and dissect the bladder and then you go and coagulate the uterines at that region where it is the ascending branch of the uterine is given, right? That is one. Now look at this. This is a second case. Same principle. Huh? See how that bladder is gone down. But see here, I had to do one additional step. Apart from pushing the uterus in the cranial direction, okay, I had to pull the bladder up. This is a very typical situation which you will encounter when somebody is having endometriosis. Everything is stuck. There is no plane visible nowhere. So in order to enhance that plane, you will have to create this. Okay. Just to fast forward this a little, that is just the ureter, no importance. Okay. Third, just remember this rule. If you are thoroughly confused where the bladder is, how it is going to come, and you are doing a total laparoscopic hysterectomy, go to the round ligament and begin the dissection from there, because the utrovesical fold actually begins from underneath the round ligament. To be honest with you, this is exactly what is followed in a pregnant uterus where we do a laparoscopic cerclage. And Dr. Shilpa will agree, because these days she is also doing a good number of laparoscopic cerclages. Okay. And she will agree that UV fold, when you push down, in order to open the posterior broadleaf, you will have to reach till the round ligament. Okay, so just keep these basic anatomical principles in mind. You may use a different set of instruments. You may use a different method of doing it. See, I am a little short-statured guy. Okay, I am short-tempered and short-statured, both the things. So what typically happens is my arm's length, okay, is such that middle port is the best port for me to operate. Okay, I can't really operate ipsilaterally or contralaterally with a flare in which the others can operate. So for me, that is the best port. For you, ipsilateral port might be the best port. Okay. Many times people will ask this question that, oh, if you are using middle port, what happens to the cameraman? The camera and the port touch each other when we want to, dissect the bladder. How do we sort out that issue? You don't have to sort out that issue, guys. You can use a 30-degree scope, and a 30-degree scope is more than enough. One more question people have asked. When we dissect the bladder, we are having a trouble that UV fold should we hold or should we hold the bladder? Listen, in a non-adherent bladder, it doesn't really matter whom you are holding. You can hold anybody and the bladder will go down, or you can not hold it at all and still the bladder will go down. In an adherent bladder, okay, there is no importance of holding any structure, because if in case your hand or your eye coordination gets used to something, that means, just to give you an example, if in case my hand-eye coordination is such that I am, just 1 minute. If in case my hand-eye coordination is such that I am used to holding the bladder up and only then dissecting, then I will not be able to do any form of dissection in a ventrofixed uterus. Understanding? That is a problem. If in case I am used to, oh, I have to see the bladder in lateral window technique only, then I will not be able to do dissection in the bladder where the uterus is stuck to the lateral pelvic wall. Okay. So don't follow that principles. Best principle is, no matter where it is stuck, okay, you have to pull the uterus up. Give cranial traction to the uterus. Second, UV fold. One thing it is important for you to remember. The bladder, if at all it gets adherent, it only gets adherent to the scar site. Okay. The bladder does not get adherent to the entire length of the cervix. Never. So there is going to be a patch of adhesions. maybe 1 centimeter, 0.5 centimeter, whatever. But the part above the adhesion and the part below the adhesion is going to be free. Okay. And third, very important thing, start developing a haptic feedback of these instruments. It will take some time. It is not going to happen overnight. It will take some time. Once you start developing a haptic feedback, bladder is bladder. Your instrument will tell you that this is bladder. Your instrument will tell you that this is cervix. Your instrument will tell you that this is vagina. Your instrument will tell you that this is the uterus. You don't have to by heart it. Okay. You don't have to by heart it. It will take some time as you pass your journey through the learning curve. But remember one thing. If you have seen our Facebook videos, time and again, we have tried to show the same thing. Take the uterus up, take the bladder up. So the space which is opened is what? It is peritoneum. That peritoneum is called as uterovesical fold. Cut anywhere in the peritoneum, peritoneum will open any which ways. Where does it have any other option? Once it opens, what you actually see is the fascia, which is called as the vesico-vaginal or the vesico-cervical fascia. If you, it's an avascular plane, by the way. And if in case you just push it down, all you have to do, like how you do it in cesarean. In a cesarean, you cut, you hold it. Sometimes, we cut it with the scissors, or we use monopolar or sharer or whatever. And what people normally do, they put their fingers to dissect that bladder down. Some people use sponge on a cotton stick or something and put the bladder down, right? In all the manners, you are not doing sharp dissection any which ways, and the bladder is still going down in a heavily vascular uterus, and that plane is not bleeding. Understanding? The same thing happens in TLH. Absolutely the same thing, but it is a much smaller uterus. If we are doing bladder dissection on a 36-week uterus confidently and taking that baby out in cesarean in 5 minutes, doing it in a 6 to 8 week uterus will not take you more than 5 seconds. Understanding? With that, the basic class on how to push that bladder down finishes. I will answer 5 questions so that we can keep the class short.
No. We have to start from the basics. Do you catheterize the bladder with Foley's? Is it
Yes,
mandatory?
not mandatory, but better to catheterize.
So what happens? I know that you don't manipulate the uterus much, but if at all, if we are using a vaginal the tube,
Yeah.
so how does it change with regard to your bladder dissection? Does it change anything? Is it better?
No, nothing is better or not better. It is a matter of perception. It does not change anything. That tube is going to help you identify the fornix. That is
Yeah.
the purpose of the tube. The tube does not allow you to identify the bladder. Okay.
No, but it gives a traction. I mean, it gives the traction because that is very what when they try and push it, na? So it just goes and sits at the vaginal vault, like how you
It
said.
does.
That it gives a delineation to where the bladder is attached. Uh, I mean, that is
It does.
yeah, visual,
It
visual.
does.
Yeah.
Yeah, it does give that. But again, as I said, it is not mandatory for people to
Mandatory,
do.
yeah. So three, when you are cutting the UV fold, okay, this is very basic. You cannot laugh. Where do you cut the UV fold? Is it 1 centimeter
Always
before the
cut it
attachment?
as close to the uterine region as possible. So that
Why?
the free end which is remaining, no, you can grasp it and give it more cranial traction so that you can push the rest of the fascia down very easily.
Okay, so you are so once we do the adnexa, okay, so
Yeah.
once we finish the adnexa and then we usually come to the bladder. So in this, I mean, do you recommend before dissecting the bladder, you recommend that the adnexa has to be done to a certain level, or it doesn't matter? I mean, you just
Adnexa is the posterior uterine compartment, posterior broad ligament. Correct.
mm, mm,
Bladder is the anterior compartment.
mm,
Do whatever you want to do. There are so many people who will go and dissect the bladder first.
yeah,
There are so many people who will do the adnexa first.
yeah,
Everything is right.
yes.
Nothing is wrong. As long as that uterus comes out.
Yeah. So till where do you dissect the bladder? See, because we have to close
Yeah.
the now it is total lapistectomy, which everybody follows, and we need to close the vault through the laparoscopic route itself.
Yeah.
So where do you recommend to dissect the bladder?
So always you will see the vagina when you push the bladder down. And we have a written rule that if you think your bladder dissection is good enough,
Mm.
then dissect 0.5 centimeters more from there. Okay. You will always have that visual clue where it has gone. Okay. You of course need to dissect it beyond the cervix. There is no question in that. But remember, anterior fornix is slightly above the portio vaginalis of the cervix. Because it is slightly above the portio vaginalis of the cervix, it's going to be little tough for a beginner to go and dissect it at that depth, because they may be scared of the bladder vasculature bleeding there.
Yeah.
Understanding? So the time, if you're putting a tube, it should go 0.5 centimeters below the tube. That means you are below that region. If in case you are not using the tube and you have a haptic feedback of the vagina, it should go below that plane, 100%. That is the single most important step which prevents vesicovaginal fistulas.
Yeah, coming to that. So when we are trying, so as you said rightly, that the traction is the most important during bladder dissection. And when we are trying to lift up, I know you don't do all these steps, but we actually do it in our routine cases where we try and lift up the entire bladder and not the UV fold only. And you also have mentioned it in couple
Yes,
of your
you should
videos.
lift the entire bladder if you want.
Yeah. So in those situations, so many a times what we see is the central part of the bladder dissection is quite easy and it goes down easily. When we come to the bladder pillars and little lateral, that is where many a times we get stuck and it starts bleeding from the uterine, or it starts bleeding from the from one of the vessels over there, or from the bladder base. And that is when the bladder dissection may be inadequate, is what I think.
Correct.
So in these situations, when they are stuck, is there anything like a troubleshooting tip that you would want to give the beginners?
Remember one thing, entire bladder and that entire uterus is supplied by the internal iliac artery.
Hmm.
Correct. Whenever you are facing a difficulty, rather than burning and charring the tissue there, it is better to go to the source and coagulate the source. Now, I do understand that people may say, but I'm not comfortable with retroperitoneal dissection. So, what to do in a situation when I'm not comfortable with retroperitoneal dissection? In that situation, remember one thing, the best thing you can do is whatever this spurter is or bleeder is, it is a point bleeder, it is a point spurter. Use your suction, irrigate that region. If in case you irrigate that region, you will find that spurter spurting from that particular point. Go with a Maryland bipolar and coagulate that. That is the best and the smartest coagulation you can do with most minimal amount of thermal damage. Correct? If in case you think you are slightly one level above and you can open the retroperitoneum and simply coagulate the internal iliac, every bleeding will stop. Nothing will happen. But if you can't do that, do this as a technique.
Yeah. So we are talking about the bleeder, and when we try and I mean, do it when we are overconfident in simple cases, usually it ends up bleeding. Okay.
Yeah.
That is when the planes sort of they stop showing up because there is blood everywhere, there is fluid, you're trying to mess around with your instruments, the suction, the everything else comes in. And in these situations, I mean, how do you think, I mean, do you change your energy source from using a shearer to harmonic, from bipolar to harmonic? I mean, all these sorts of the circus. I mean, is it really worth the effort that we are trying to reduce the lateral spread? I mean,
No. Remember one thing, energy source is energy source. All energy sources produce heat. Understanding? Better option is the understanding of anatomy, that this is a blood vessel, and blood vessel is best coagulated either at the tip of its spurting point or along the length after skeletonizing it. So follow that principle rather than changing instruments. If you are using a Bissinger bipolar is absolutely brilliant, okay, in coagulating anything you want to coagulate. Don't change to harmonic. If you are using harmonic, don't switch to bipolar. If you are using sharer, stick to sharer.
okay. So today we are only talking about non-scarred uterus.
Yes.
And in these situations, in special situations, especially in postmenopausal women, we
Yeah.
find it very tough to find the plane, especially if it is a thin postmenopausal women. So if there is no fat and there are no planes because of lack of hormones. So in these situations, what is your advice?
Madam, the minute you give cranial traction to that tiny postmenopausal uterus, okay, The minute you even just hold it up from the round ligament, okay, and you cut the round ligament, automatically the leaves of peritoneum will separate because of the effect of CO2 going inside that. If you cut the anterior leaf flush to the uterus, automatically UV fold will open and the bladder will get pushed down. There is no problem in that. It does not really change your method of doing surgery. Doesn't.
So, see, one more point for better bladder dissection. Do you think cutting the round ligament as lateral as possible will help? I mean, is it a point?
The rule of round ligament is to cut it as lateral as possible in any surgery which you do where you want to cut it.
No, but see, what we are trying to tell is like stay as close to the uterus as possible to prevent the injury to the adjacent structures. And I mean, I think that's what has been taught to everyone, even in the
When you
textbook.
are close to the vasculature of the uterus, stay close to the uterus. When you are at the cranial part of the uterus towards the adnexa, stay far away from the uterus.
Yeah.
Simple.
I think this is a very good point where it is to be remembered that the round ligament has to be cut as lateral as possible, and that itself will open the plane and that champagne effect, whatever effect you want to call. I mean, that itself will dissect quite a bit of the bladder. So, what is your take on because you handle so many fistulas? So, where do you think people go wrong? Because I know the moment you see a fistula, you always tell which step must have gone wrong. I mean, I have seen you do it. So,
Yeah.
where do you think usually people go wrong? Because many of them would be in simple cases where the fistulas have happened.
50 to 80% of fistulas will happen in cases where you did not expect it to happen.
Yeah.
That is the first thing. Second, very much important thing. Normally, even if people have dissected the bladder adequately, they are very strongly bound on suturing the vagina very tightly. So what they do is they take the full length of the vagina through the entire thing. In that, inadvertently, the suture passes through a small part of the bladder, right? That is the typical reason why you have a supratrigonal fistula. Because remember, in order to take the vault in open surgery or wherever, we want to use Vicryl number 1. And if you normally see how we are taught in open surgery, how to take the vault, we will have 5 alleys on the anterior wall, 5 on the posterior wall, correct? And all alleys is pulling that vagina somewhere, correct? In that situation, the natural human mechanism is to pass the suture underneath the place where you are holding it.
Yeah.
Which is why you go inadvertently in very more depth than what you require to go, which is what causes the fistula. If you ever sit down peacefully and listen to what they are saying, the only answer is like, sir, kuch nahi tha case mein. That means everything went off so well. This is the point. Okay. And see, when it passes through that small little part of the bladder, you can't really see it. And even if you see it, you are afraid to then push it down because you want it is going to bleed, and then who will manage that and all these things. Understanding? So avoid that. Actually, you just require a pincer forceps to hold on to the vault and suture it beautifully. You don't really require alleys, fallies. Nothing is required. Nothing is required. So that is a
So,
point to be kept in mind, I think.
okay. So, yeah, what happens is like you do a bladder dissection and you start suturing the vault. Then you realize that there is no length of the vault at all to suture and the bladder is still there. So in these situations, what is your advice that how they should actually go and do the rest of the bladder dissection?
Yeah. Best is to always hold the vault at the midpoint, center of the vault, and again pull the vault cranially. Remember, vagina is a distensile organ, so it will go up by another 1 centimeter. You will get that plane where the bladder will be pushed down. Understanding? It will never happen that you can't push the bladder down. It is very
So
simple.
yeah, when you have dissected the bladder in a non-scarred uterus and you are not in the right plane, when you have cut a few bladder fibers,
It
you
will
see that
bleed.
there is bleeding. Okay. So you think I mean, it is okay to go and coagulate that bleed and go ahead with your dissection.
It is okay to coagulate, but a bleeding is an indication that you are in the wrong plane. So you need to change your plane.
Correct. What is your advice on using a swab even in laparoscopic surgery to actually try and push the bladder?
The maximum amount of bladder trauma happens because of that swab. Because swab is a blunt dissection. And if you've cut the detrusor, right, and if you pass a swab over it, see, we are not going to put that swab on the vagina and then, madam, give tender loving care to that vagina. Correct? No. People will take that swab and drill that swab there. So if you drill, it will tear off. Okay. Don't do that. The principle of dissection, of any dissection, is sharp dissection. So do sharp dissection. Simple take home point.
So when is it that you advise in non-scarred uterus to use scissors and not any kind of energy source? Is there any circumstance, situation?
Not, I mean, I'm not very comfortable using cold knife current, madam. I will either use monopolar or bipolar somewhere.
Okay, yeah. I think we are good. I think it was excellent, excellent discussion on bladder dissection in a non-scarred uterus. So I hope people give us feedback as to how we can actually improvise on this, because these are, I think, practical situations where many would have faced this problem. And I really hope that this gives the confidence and a boost to start doing more and more endoscopic surgeries without complications, and with whatever the infrastructure and the basic instruments that everybody can manage with. So